Good afternoon, ladies and gentlemen. On behalf of the Western Regional Health Authority Mental Health Unit, the Department of Sociology, Psychology, and Social Work of the Western Jamaica campus of the University of the West Indies, the Ministry of Health and Wellness, the Pan-American Health Organization, I want to welcome you to day 2 of our Mental Health Conference, Week of Presentations. We promise you that this evening will be as stimulating and as engaging as our last, and we look forward to having you for the remainder of the week. We want to take this opportunity to remind you of the week of events that we have ahead. Each evening we will begin at 5 p.m. and conclude at 7 p.m. Each evening we will have a different set of presenters that will tackle issues that are pertinent to mental health and wellness. This afternoon we have the able consultant psychiatrist, Dr. Winston Delahaye, that will be your moderator for today's presentations. We thank you. Dr. Delahaye?
Thank you very much. Let me thank the organizers for, one, setting up this well-organized, I must say, conference, for inviting me to be the chairperson for this evening, part of many others to come tomorrow, Friday, Saturday into Sunday. I think, certainly as a psychiatrist, I feel very happy, very proud of my colleagues that they're able to put on a conference of this nature with the theme, investing in mental health. Mental health isn't necessarily where we're going to make a lot of money, if that's part of the reason we have any healthcare system. In fact, the well-known downward drift theory where persons affected by mental health, even if they were in a particular socioeconomic status, by virtue of their illness, drift downwards over time. And so it's where nations must recognize the importance of mental health, and as our theme says, investing in mental health, recognizing that there's no good health without good mental health. More specifically, this evening we're looking at the time for action is now. That's our topic. It's never too late to do something. And as mental health professionals, we recognize the fact that persons may not be aware that they have challenges. Doesn't matter how late it is. The point is, if you never recognized and then came around to seeking help, you probably just wouldn't do better than you can at any time, any point in time. So thanks again. This evening we have 2 excellent presenters, and our first presenter will be Dr. Earl Wright. We all know Dr. Wright very well. In fact, I'm reminded that he's a member of the team there in the Western Regional Health Authority, in the mental health group there, having served there, Dr. Wright, I think for a number of years.
No,
so Dr. Wright is certainly well known in our circles, finished here with us, then went on to the US doing psychiatry in a significant way, and certainly in the true sense of giving back, returned to Jamaica and was our director of mental health for many years. Dr. Wright is one of the psychiatrists who you can call at any time for any comment on anything, literally. And we appreciate that, having come through the system here as well. And so Dr. Wright presents this evening on the topic, public health and the economic burden of mental illness. And so I'll ask Dr. Wright if he could just take us from there into his presentation. Thank you very much.
Thank you very much, Dr. Delahaye. Always a pleasure being in the Western region. It's one of my favorite areas. Actually, I come from the Western region. Gonna talk to you about mental health and the burden of mental health, the public health and the economic burden of mental illness, and also the economic case for spending on mental health. One of the things we know, and I don't know if anybody will disagree with me, that mental health is not a priority area for policy makers even today. I know that you hear all the time that mental health is a priority, but I want anybody that really thinks that mental health is a priority to send a note by chat to me, because I've heard it many times, but I still don't believe that mental health is a priority for the policymakers. But it should be. And mental health is a public health issue. Public health is important due to aiding and prolonging life. Through the prevention of health issues, individuals can spend more of their years in good health. Without public health, we wouldn't have that. Public health detects health issues as early as possible, responds appropriately to avoid the development of disease disorders. Public health is the science of protecting and involving the health of people and their communities. And the work is achieved by promoting healthy lifestyle, researching disease, injury prevention, and detecting and responding to diseases. The public health vision for mental health in Jamaica is to improve the mental health of the people of Jamaica so that individuals will attain a state of well-being where individuals will rely on his or her own ability, be able to cope with life's stressors, work productively, make a positive contribution to his or her community, and importantly, live harmoniously with others. And as we know, mental health is a continuum. You have mental health, and it moves all the way to severe mental illnesses. Mental illnesses and behavioral disorders causes alteration in thinking, moods, or behavior, or a combination, and is associated with much distress and impaired functioning. We move towards mental health, a state of well-being. We have self-awareness, resilience, coping skill, productivity measured by positive contribution to society. So it's a continuum moving from one, and it's neither one or the other. As I always say, everybody, bar none, will have a mental health problem sometime in their life. What causes mental illness? It's generally accepted that mental illnesses are brain disorders. Therefore, the importance of understanding optimum brain development. If you are going to have good mental health, then the brain must be developed appropriately in the early years. And we're talking about sensitive and critical periods in brain development. During the fetal development, genetics and the uterine environment is pretty important. And I think our healthcare system has basically taken care of that with regards to the uterine environment and protecting us from radiation, drugs, and nutritional, very great emphasis on nutritional status. And then we have the early childhood development, 0 to 6 years. These are critical periods in wiring and sculpturing of the brain, and influenced again by what you inherit from your parents, your genes, and the environment. And reminding you that the first 8 months of life, you have ×8 increase in synaptic density. And during the early years, it's refining of these connections, and those genes that are stimulated are turned on. Those that are neglected are turned off. So the first years, the first 6 years of life really lay the foundation for mental health as a whole. And if we look on this, one of the important things is during the preschool period. And if you look on this vision, and we all know that if you if you don't correct vision early in life, then you are not going to have optimum vision. The same thing with hearing. You notice the optimal period is below. Also, your biases, habitual ways of responding, and emotional control. If you notice here, you see that it happens early in life. Let me do that again. The preschool years, the early years, vision, hearing, and we all know that, but the habitual, our biases, and emotional control. And emphasizing again, in Jamaica, many of us have problems with emotional control. And these are the years laying the foundation for personality disorders and problems with some of our behaviors. Numbers and social skill continue, and language much later in life. But it's really the first years of life here that I think the emphasis needs to be placed on for mental health and behavior. Again, if we look at this is a healthy brain, and you notice the high activity in the prefrontal cortex. If you look at an abused brain, you see the lack of activity. All here is dark. Nothing is happening here. Nothing is happening here. Behind here, the primitive instincts are still there. So this is what happens when a child is abused, or the functioning of the brain, the stimulation is not there to use develop the brain cells. But if you look on what we're talking about, the spending of money, there's a mixed match between this brain malleability and the spending on health, education, and social services. You notice that very little happens until after age 6, 7, and then it gradually increases until a lot of the health and education happens in the older age group. This is another example. In the prenatal period, when the brain is, the influences on the brain is happening, very little money is spent. Preschool, a little bit more, but not much. Elementary school, secondary school, it's much later in life that you have lots of spending on health, education, and social services. But if you want the outcomes to be good, then you need to spend the money when you can influence the brain's development. And we know Dr. Delahaye talked about poverty. And you know, poverty, there's increased stress with poverty. And then if you have an increased stress, then you are more likely to develop mental illnesses. And if you have mental illness, the downward drift that Dr. Delahaye spoke about, going to unemployment and then back into poverty. So this is part of the cycle that needs to be broken. There's also a high burden and interaction with physical health, leading to a high economic cost. There is a significant cost of both mental health affecting physical health, and the burden that also occurs with how the precipitation and outcome for physical health. All back again to stress the stresses of life affecting the brain, stimulating the brain, secreting corticotropin releasing factor, stimulating the pituitary, the limbic, pituitary, adrenal system, and then you have the cortisol being secreted along with other chemicals. And therefore, stress influences a lot of the outcome of both mental disorders and physical disorders. And if we look at the top 10 sources of time lost to disability globally for all medical causes by percentage, you'll notice that the mental and behavioral disorders are by far the most problematic, taking up 26%, musculoskeletal taking up 14%, infectious disease 8%, nutritional deficiencies 7%. So if we look at it, we see that the mental and behavioral disorders are the one that really costing us a lot of money. If we go to the DALYs, disability adjusted life years, we see that anxiety disorders takes up a lot, and depressive disorders seem to be the most debilitating mental condition that causes increase in the DALYs and increased incidence of mental disorders. And in the adult life, the general prevalence of mental illnesses increases with age. There's an upward tick in the adolescent years, but there's also an increase as one gets older, increased incidence of depression. And it's estimated that the prevalence in the elderly ranges from 8 to 20% in the community. And if you have other medical conditions, you increase the risk. And many times the depression goes undetected and untreated, especially in the elderly, where it's seen many times as a normal aging process. There's an interaction also between physical health and mental health, and we need to treat them together. We need to link physical health and mental health. They shouldn't be separate at all. The relationship is not only linear, but cyclical. Depression predisposes individuals to myocardial infarction, and myocardial infarction predisposes an individual to depression. Panic disorders associated with high incidence of asthma, and asthma high incidence of panic disorder. Same thing with diabetes and many of the other chronic diseases. And in some of these diseases, you have a direct insult to the brain. For example, if you have depression for a long period of time, you are more susceptible to cardiovascular diseases because the cortisol that is at a higher level with major depression circulated in the blood causes atherosclerosis. Therefore, the higher incidence of myocardial infarction. So you have the prevalence of major depression in patients with physical illness, hypertension, some of the studies up to 29–30%, myocardial infarction up to 22%, epilepsy, depression is very common, 30% and over, stroke up to 31%, diabetes 27%, cancer 33%, HIV/AIDS up to 44%, and tuberculosis up to 46%. In the general population, in some countries, they tell me it's up to 10%. In Jamaica, it's usually between 10 and 18%, some of the studies are showing. So depression is a very prevalent mental health condition that costs all countries quite a bit. And in Jamaica, where the prevalence is also high, is costing us significantly. Also affect the treatment, affect the rate of a health condition. So it's associated with risk factors for chronic disease, smoking. When your mental health isn't so good, the alcohol goes up. In Jamaica, you see the guys, if you go on many psychiatric wards, you see many patients smoking, or they try at least to smoke. When your mental health isn't so good, there's reduced activity, you don't feel like exercising, and the increase in comfort food, poor diet, leading to obesity, and you have, with stress, you have increased hypertension because of the release of norepinephrine, etc. So we're talking about the biological effects of depression. You have the serotonin metabolism and the alteration of cardiac function, platelet aggregation, and vasoconstriction. And very important is the cortisol metabolism. Increased cortisol leading to inflammation, excessive clotting, and the hypertension, the deposit of fatty tissue around the waist, and diabetes. So we're talking about, always come back to stress. Stress, and we take in stress through all our senses, the eyes, our ears, our touch, etc. And some of it starts internally within the brain. And the chemical, the biological response to stress from the limbic area through the hypothalamus, the corticotropin releasing factor to the pituitary, through the autonomic nervous system affecting all the organs of the body. Very straightforward to see how stress affects the whole body, how from the heart to the adrenal glands to the liver, etc., and to our cardiovascular system. And if you are depressed for a long period of time, then this feedback loop shifts, and the cortisol level, even at rest, is very high. So you have a shift in the cortisol feedback system, so you don't need a stressor. Or you have a kindling effect, where the slight stressor will shift the system, and you have a high level of cortisol affecting the brain, causing effects on the specific area, the hippocampus and the amygdala. So there's a physical outcome to not managing stress and not treating depression. Social structure plays a major role in mental illnesses, where a higher burden is found in areas of conflicts, disaster, and violence. And we in Jamaica have a high incidence of violence. Our murder rate is one of the highest in the world. And we are in the hurricane season. So we have hurricanes and disasters from time to time, and the violence in our society is ongoing. In the Caribbean, societal violence and natural disasters may be major factors contributing to the burden of mental illness, such as depression and anxiety, and to some degree personality disorders. And now we have an increased stressor. Now we have COVID-19, which is a pervasive long-term stressor. So we've been talking about all the stressors and what it does. So there is a major cost, an economic cost to the country, direct and indirect. And the United States, it's estimated at $148 billion. That's for the treatment of all the diseases, 2.5% of the United States GDP. And the indirect cost is 2 to 6 times greater than the estimated direct costs, because you have the social service needs, the loss of employment, reduced productivity, premature mortality, family and community psychosocial and economic impact, increased levels of crime and social safety, and stigma and discrimination. And these are some of the ways that they have costed out the economic cost. Not going to go into it, but you say the direct cost, healthcare costs, medication, physician visits, hospitalization, plus the productivity, work absence or early retirement, income loss due to mortality, disability. This is in mental health, one of the major part of mortality is suicide. In Jamaica, we don't have much suicide. We have a high rate of homicide, disability, and care seeking. And there are other ways of estimating or working out the economic burden of mental disorders. In Jamaica, we try to estimate, to work out how much it's costing us. So it's possible to estimate the indirect cost. And if we choose depression and we choose the number of days that is estimated to be missed by the labor force, we looked at the cost of the work time missed and the costs derived from premature deaths of a depressed person who committed suicide. And the major economic costs work productivity is absenteeism. So we looked at the full work days, sick days per person per year as a result of depression. And in Jamaica, we found out that it was approximately 10 days. So if we do that, the number of work days in a year, 280, and that works out to GDP per capita, 134,000. So we're talking about 480 per day. And we looked at the missed days for individuals. This was done some years ago. And we also looked at what we call presenteeism. And presenteeism is when somebody comes to work, but they are depressed, or they are anxious, or they have a mental health problem. So they are there in body, the body's there, but they are not doing the work. And that's one of the major problems about mental disorders. The average number of work days with reduced productivity as a result of major depression. And we figured it's approximately 5 times that of the last sick days. People lose more from productivity, from presenteeism than by being absent. They come to work and they don't do the work. Full productivity of these days for the person in the labor force would be 4 billion. That was the estimate that the health economists gave to me. So if we say that the productivity is reduced by half for these persons, will still come out to a large sum, 2 billion. And if it's reduced by 3/4, we have over 3 billion. So if we look at one disease, mental health, the appropriate treatment of a single mental health problem, depression, will therefore lead a calculated benefit to the economy worth billions of Jamaican dollars with a significant return on investment. One of the things I've learned that when you do the studies here, a lot of people will question it. But if you get an outsider to come and do it, you'll find that it becomes much more believable. So PAHO did a study in Jamaica, and it's the investment case and prevention and control of mental health conditions in Jamaica. And this is what they found. The health and economic impact of mental health conditions in Jamaica. What you see here is a prevalence of 3%. What that really is talking about is that 3% of the individuals who are seen in the public health clinics are treated for clinical depression, major depressive disorder. And 4.1% of individuals treated in the public clinics are seen for anxiety disorders. And 80% of the individuals are in the public clinic are related to mental illnesses are from psychotic illnesses. But they estimated that the labor productivity lost projected in 15 years would be 39 billion. And the social costs would be 21. That is, if we treated effectively these disorders, we could save 39 billion for labor productivity in 15 years and 21 billion in social costs in 15 years. So it's a significant number and significant cost if we don't treat these disorders. So Jamaica could reduce these social costs and economic losses by implementing the WHO GAP action, and we're talking about screening for depression and treating the mental health conditions by intervention to prevent and control mental health conditions. And the intervention for depression is very straightforward. Every individual that comes to the clinic, just like how you screen for high blood pressure, you take the person's blood pressure, you should also ask them the 2 screening questions. During the past month, have you been feeling depressed, angry, irritable, sad? During the past month, have you been not interested in things that you used to enjoy, etc.? Very simple 2. And if the answer to those 2, either those 2 is yes, then you do a full screening evaluation. So if we started to screen for depression alone, you would be the return on investment of scaling up treatment for 15 years would be 5.2 for depression, 5.5 for the anxiety disorders. We're talking about treatment, the support system, and antidepressant medication. And if we scaled up the psychosis treatment, you'd get a 1-to-1 return on your investment. And we're talking about the incidence of depression in Jamaica ranges from 10 to 20 per 100,000, 10 to 20%, and anxiety, it's higher still. Again, the return of investment would be 4.2 if we scale up treatment. For each dollar that we invest in mental health, you're gonna get 4.2 return. So you have both the local study and you have the study done by PAHO and the United Nations Interagency Task Force on NCDs, that over the next 15 years, scaling up treatment for mental health condition in Jamaica would lead to 229,000 cases of depression and anxiety averted. This is a number of cases of depression and anxiety we could avert. And more than 75,000 healthy life years gained. And this works out to 60 billion, 3.3% of GDP in 2017, productivity gains and social benefits gained. I wonder if there's a better argument. But if you remember at the beginning of the presentation, I said very clearly that mental health is not a policy priority. And I have been hoping for many years that with this sort of evidence that we could make it a public health priority. So we're talking about screening for early recognition and effective treatment of mental disorders offers an investment opportunity in individual health and overall health status for Jamaica. So if you look at the cost benefit, if they said that it was a one-to-one investment for psychosis, and our psychosis, schizophrenia is the main one. And as you know, schizophrenia is a chronic, progressive, neurodegenerative brain disorder with a prodromal phase leading to presentation of major symptoms of thought disorder, delusions, hallucination, impaired functioning in the second and third decade of life. And this is the progression. Usually premorbid, and then you have a prodromal phase where you see the child in the early adolescent have a little strange behavior. Sometimes you can't pinpoint it, but then during the late adolescent and early adult life, you usually have the first clinical, this presentation where the schizophrenia decompensate. And it's usually a progressive disorder. However, if you catch it at this phase, then you can level off this curve, or at least level off it at a higher, increase the person's level of functioning if it's treated effectively. If it's not, then there is a deterioration, and then you have the institutionalization, and we have 400 plus discharged patients now that have reached the deterioration stage where their level of functioning will need various levels of support and protection because their brain are at this stage and something really at a lower level. So we need to effectively recognize schizophrenia and treat it effectively. The cost of long-stay patients in an institutional setting is estimated to be about 50% more than the cost of community treatment and care. A reduction in cost does not include running two systems simultaneously and the hidden cost of the burden of care for the family. And this is the WHO pyramid. And as you see, long stay facilities, specialist services, very high cost. The community mental health services, psychosocial, less. Mental health services through primary care, less. And then you have the community support systems. And we always do our studies here in Jamaica. And the cost in different settings for patients with severe, persistent mental illnesses. Bellevue costing $180,200 per month. If you go to KPH General Hospital, it's about $166,000 per month. If you take the individual and you give the family a grant, and I think the grant should be much higher than this, then we're talking about $12,000. That is part of the PATH benefits, etc. I think if we're going to give families a grant to take care of the mentally ill, we need to work out a higher cost than this. If you go to the residential home, private homes, you have the $58,700 per month, and infirmaries, you have $67,000 per month, and NGOs with their support from other places works out at about $22,000. But realistically, it's really the public infirmaries that's going to give you the level of care and the control necessary, but we should also include the family. If we can get families with a substantial grant to take care of their family members, then it will be, the brain will react much better. No question that if the patient is in the community, then you are going to have a better outcome because of the plasticity of the brain and the stimulation that occurs at the community level rather than in an institution. The brain reflects what it is around. So taking into consideration the life cycle of brain development, mental health and mental disorders, and the economic burden, these are the public health recommendations. And I take you back to this, where we're talking about the brain's plasticity versus what is spent. And if we're really talking about influencing the brain, then this is the period. This is the period when we need to increase our spending and move some of the money across to here, or get some more money to spend in this area. No question to me about that. Therefore, the recommendation, and it's a very specific recommendation, the development of a cadre of community health aides trained to make regular visits to homes of vulnerable children to teach mothers and fathers and other family members how to interact with their children in a loving and caring manner and to improve their parenting skills. And we're talking about early childhood stimulation. And this brings you back to this slide. Not going to allow you to go through it again. Remember, with preschool years and emotional control, the habitual way of responding, that the brain, by this time, most of the inputs, the hardwiring has taken place, and to a less extent over 4 years. There is another opportunity in the adolescent years to stimulate the brain. But if you don't do it right here, then it becomes more difficult then. So this recommendation is based on the research conducted at the Tropical Metabolic Research Unit, now the Institute of Caribbean Health Research at the University of the West Indies, initially by Dr. Sally McGregor and now by Dr. Susan Walker et al. This research showed in Jamaica that weekly visit to mothers of malnourished children to teach them how to play with their children reduce malnutrition and improve cognition in children. And the follow-up study, they've been following these children for over 20 years, showed the benefits to the children remain into adult life. The productivity increased, the level of violence decreased. And there's also another significant side effect. When community health aides go and talk to the mothers, they were significantly less depressed than their heirs. So when a community health aide go to the gate and knock on the gate and interact with the mother, you have both the children doing better and the mothers doing better. But it's also important that the selection of the community health aides be appropriate. They should be from within the community, so they know the community very well as best as possible, and so that they can interact. They have the trust of the individuals in the community that they serve, and they link up to the appropriate clinic, public health clinic, so that the community nurse, public health nurse, etc., can have this link through them to the community, and specialists, when they need specialist help, they can refer. Also, to improve the cadre of community health aides, mental aides, this is an increase now. Trained to intervene and mediate conflict in order to break the cycle of violence due to retaliation and vengeance. These persons need to operate both within the community to prevent violence and within the health services to counsel the many persons who are injured by violent acts and seek treatment. So when you do an intervention, so there isn't the cycle of violence within the community. Most important, the strengthening of the community mental health services in order to identify, diagnose, and treat the mentally ill early. Usual public health to identify and recognize early and treat early and involve and support the families of the mentally ill to better manage their family members, to respond promptly to emergencies in the community. That's the community mental health team, and help to rehabilitate the mentally ill, and to conduct health education within the communities and combat the stigma and discrimination associated with mental illnesses. And again, we're talking about the further integration of mental health services within primary care so that more medical practitioners and health providers can better identify persons with mental illness. We shouldn't be having 3% of depression and 4% of anxiety disorders being treated in the public health system when we know that the incidence prevalence is much higher. So we need to do something about that. I don't think that the private practitioners are really seeing the rest of the individuals with major depressive disorder or the anxiety disorder. And therefore to continue to strengthen through training program for community health and for social workers. And this is also very important. Establish more safe green areas such as Emancipation Park and Hope Gardens, where persons of all ages can socialize, recreate, as well as walk, jog, exercise, play sports and games. These areas are essential for the mental and physical health of our country and the well-being of our communities. I want to thank you. Hope this has helped, but I'm looking forward that I'm hoping somehow, knowing the high economic burden of mental disorders, that we can really make mental health a priority. Thank you. God bless.
Thank you very much, Dr. Wright. A really excellent presentation. One I've heard you touch on over the years. In fact, I'll tell you, when I first heard you speak on disability-adjusted life years, things like presenteeism, absenteeism, as a young resident, I was really I felt exposed. And then I did public health, as you know, and the penny dropped. And the unfortunate thing is, that's many years ago and we're still struggling with all that. You certainly clearly highlighted the benefit to identifying and treating, in particular, depression. And that's the one illness, certainly in psychiatry, I'm sure we all agree as psychiatrists that can't wait for psychiatrists to manage in patients. We must have that being identified and managed in the clinics in primary health care. Unfortunately, the foresight required to see the benefit of investment in the things you just discussed, which would traverse a life cycle or cultural cycle, doesn't exactly fit into a 4 or 5 year cycle. I'm sure you know what I mean. And that's sad, unfortunately. However, we must ensure that we knock on the doors and knock them down if we have to, of those who certainly are in a position to put things in place and allow for the expenditure, which can only benefit all of us, not to mention, as you pointed out, the role of violence and that whole connection with all the developmental issues you just pointed out. So let me thank you again for an excellent presentation. As always, Dr. Wright, the questions and answers will be left towards the end. And a very good segue will be Dr. Dianne Campbell-Stennett's presentation. Now, Dianne is the Regional Technical Director of the Western Regional Health Authority. I had the pleasure as Chief Medical Officer at the time of working with her over a number of years and on many things, the least of which was not the Cornwall Regional Hospital. I almost said the back-to-butt issue. Let's just stick to that. And so Dianne really comes very highly trained and experienced in public health as required for the job she does, being the Regional Technical Director for the Western Regional Health Authority. So let's invite Dianne now to give us her presentation entitled The Integration of Mental Health in Primary Care, the challenges with integrating mental health in primary care. Dianne? Are you there, Dianne?
I am here. Thank you very much, Dr. Delahaye. Thanks, Dr. Wright. I'm trying to find my camera. Okay, I'm starting the video. Okay, good. Good evening, everyone. Thank you very much, Dr. Delahaye. Thanks for that wonderful presentation, Dr. Wright. Let me first start by congratulating Dr. Crossman and her team for putting together this conference, a series of lectures this week. Mental health is something that is very, very dear to me and important. I would like to think that I am a strong advocate from where I sit. So this evening, I'm going to take you through the perspective that we have in terms of from an administrative and an implementation level. and look at some of the challenges we really are having in terms of this issue. We already would have been introduced to the definition of mental health and mental illness. A lot of times people think of mental illness and forget about the fact that it is really a spectrum in terms of where we are, in terms of our wellness when we think about our mental state. So the presentation really will be looking at the rationale as to why mental health services is a primary care issue. What does integration really mean? I want to actually look at a best practice. I'm going to use some tools to assess how we have been working in the Western region with integration and to look at some ways we could move forward with it. So Dr. Wright did a lot in terms of why mental health is so important and it is a primary care issue. We do have a high burden. So WHO as well has issued these findings from 2008 and made some very important findings as to why we need to look at primary care and integrating this mental health services. It's because the burden is really great. Mental and physical health problems are interwoven. One of the things in primary care is that we really think of holistic care. So we're not looking at the patient in just a physical state, but we want them to be well. The treatment gap for mental disorders is enormous, and I'm going to show you some of that. Primary health care provides good access points. We have in our region alone over 500,000 visits per year. So there is a large number of persons who can access the service and who have been visiting these facilities. In a primary care setting, it really promotes the respect of human rights. It allows persons to make choices and freely access care. It is more affordable and cost effective, and it generates very good health outcomes. You've seen some of this epidemiology already in terms of where we are with the mental illness, and the fact that in 2015, depression was estimated at 4.4%, anxiety disorders at 3.6%, and schizophrenia and psychosis was much less than that, but that is what we focus on all the time when we talk about mental health. In Jamaica, or Jamaica Health and Lifestyle Survey in 2018, found that most people reported depression symptoms in 18.5% of people. In the Western region, 6.4 to 18.4% was found. Trelawney had the lowest with 6.4% of the participants reporting the prevalence of symptoms of depression. PAHO WHO, though, estimates that we do have similar findings to the global picture in terms of where depression actually is. As I was speaking, though, primary care services are well utilized across the entire age range. So we have all children coming, we have women, we have men, we have urgent care, and we have non-communicable disease treatment. So a lot of services are offered where persons can access care. When we looked at the visit store facility and what we treated mental health conditions, psychosis and schizophrenia accounted for 80% of the persons that were treated in our facilities. Of course, every time I give data from my region, I have to have a little caveat to say that our health information systems really pose challenges in terms of us getting data, up-to-date data and accurate data. But it is what we have, so we have to use it. So this is just to give you some more details in terms of looking at the caseload, and just to say that what I'm telling you is still true today. So that data would have been about 2008 from the gap that was studied at the WHO AIM study that was done in Jamaica. But when I looked at the 2007 to 2018 data and the 2017 data, it's still at 88.5% and 87% being treated for psychotic disorders. Remember the data presented before where you're seeing that psychosis would have been much less than mood, disorder or anxiety disorder. So the number, so there's really a gap in what we're doing in our facilities at this point. It's important also to remember about this interaction with physical health. Some of that was discussed, so I won't go back into that, but that is also important. We use this to remind our own clinicians as well who offer care the importance of paying attention as well to this aspect. And I saw this data that was presented by Dr. Wright as well, because I thought that this was so important to highlight that if we were able to scale up just interventions targeting depression, anxiety, and psychosis, we would restore over 75,000 healthy life years of Jamaican population and provide 60 billion in benefits and only spend $14.2 billion. So I mean, that is ridiculous in terms of return on your investment. So we have looked at why it is important to do it, but what does it really mean for us? Again, WHO shows us this mix that you need in terms of the optimal service mix, and you will see that majority of persons require self-care and informal care. So as you go up the specialized services, less persons require that. It is at a higher cost as well. When we looked at those case studies that WHO did in 2008 about integration, they picked out 10 things that were needed to ensure integration happened. So the first thing they said was you needed policy and plans to incorporate primary care for mental health. You needed advocacy to shift attitudes and behavior. You needed adequate training of our primary healthcare workers. What you're asking the team to do in primary care must be limited, defined, and they should be able to accomplish it. We need to have specialist mental health professionals and facilities to support what is being done in primary care. We have to access the medication. We have to keep this in mind. Number 7 is important. I keep reminding myself that it's a process, it's not an event. So you must keep at it. You must have a mental health service coordinator. You have to collaborate with other sectors, community workers, volunteers, and you need resources to do this. So it really means providing the service at the first point of contact with the health system where the people live. There should be some mix in terms of public, and we already started this model from in the 1960s to make it, to do this integration. There are 2 general models when I looked at it, and that you have staff specially trained in the clinics that see the patients, or you have the general physicians who sees and treats the patients supported by those mental health professionals. And we'll go back into this. So I wanted to pull Belize. I pulled Belize as a success story. They have a small population, bigger than my region. Our region has smaller than our region. We have over 472,000 population. But the healthcare delivery system is similar in terms of its organization. There's 1 psychiatric hospital, an acute psychiatric ward at another facility, and 1 mental health outpatient clinic. That's what they started with when they started the process of integration. What they started to do though was to train psychiatric nurse practitioners, because they had 1 psychiatrist at the time which was visiting, and so they had to expand their services rapidly. So they trained psychiatric nurse practitioners with a 10-month training program, and they were deployed to outpatient clinics. They did home visits as well as mental health education in schools and communities, and they were given special prescriptive rights for a limited range of psychotropic medications. The medications were made available to all the district hospitals and polyclinics, and workshops were convened with all members of the primary care team. And so the system worked very well, and PAHO actually helped to train and continues that relationship with the psychiatric nurse practitioners there. So their outcome in terms of their success is they saw an increase in the number of visits in primary care and a 2/3 decline in hospital admissions over 5 years. So where are we now in our integration process? And I don't really have anything. So I have some stars I've put there to start to look at where we are. So I give 2 stars and 3 stars and 1 star. So that's just my subjective assessment of what is happening. We do have some commitment. I know Dr. Wright says we do say it's a priority. It's always a priority program. It's one of the 5 things that mentioned every time that we're doing it. There is formal policy and legislation in place. We do have our strategic and operational plan, and the mental health gap action plan was developed, and we started our implementation, but it has slowed somewhat. We do have budgetary support for staff and our pharmaceuticals, and I'll show you some of the other things that we are getting for that. We do have strong advocacy. I think we do have that at the national level. There is the Jamaica Task Force on Mental Health and Homelessness recently, who actually was part of that investment study, looking at the money and the reason for doing that. But we need more advocacy in the middle area and on the ground to really drum it up. I think while you may have it externally, there's still more needed on the ground. Our mental health board, which plays a very important role in governing what happens, does definitely need strengthening and a reinvigoration in terms of what needs to happen. Training our primary care workers, I give them 1.5 star. I still think pre-service training in schools need to be strengthened, not only for doctors and nurses, so that it needs to be something that as a healthcare worker, part of your training, the prevention focus needs to be improved. So we talk a lot about treating mental illness, but in terms of prevention of mental illness, communication, counseling skills, those are things that really need to be improved. In 2009, the WHO did a study that I mentioned before, and they had looked at in-service training and thought that 3% of doctors, 1% of nurse, 37% of other categories were trained that year when they looked. In terms of the frequency, it was really 2-day refresher training in mental health. 8% persons actually did that, 50% of the nurses and 20% of other workers. That was in 2009. Fast forward to where we are now. Have we made much difference in our region? We conducted a series of mental health gap training in 2017 to 2018. Sessions were held once per month. I think we may have missed a month. We had 44 persons trained, including 8 nurses and 4 medical officers, and we did train the HIV team members in 2019. Our major challenge is, if you look at that time period, which seems to be a year, but add on the 2 now, we have a high turnover of our medical officers. So we have to continue this training. It cannot be just a one-off activity. It has to be an ongoing exercise. We have inadequate health information systems in place to monitor and manage. So I wanted to be able to provide you with data to look at what was happening in our clinics, but I could only get the data for those that were trained for the HIV team. And in 1 month, you will see that 28 persons were diagnosed with conditions. The clinicians who were trained in Westmoreland do not currently work at that treatment site. What I find encouraging, even though it's 28, is that you will see that the disorders that we're targeting are coming up. So they're identifying depressive disorders, mood disorders, and we're happy for that. This has been an ongoing thing. So depression screening chronic disease patients has been something that has been in our guidelines for years, but we have had challenges monitoring and implementing it. So in the region, we started last year trying to collect this data. And so for 2020, we can look at saying that we are seeing some work being done in this area. and it improved in the last quarter. So we are drumming this up to see where we can get in terms of actual work being done. This is definitely a 1-star. Remember, we're going through the different areas. So we're looking now at availability of mental health specialists, which is important for integration because you really want to have that support in place for your non-mental health staff to be able to refer to be able to receive coaching and training from. And this is the data from 2009 when they looked at the staff ratios for psychiatrists, medical doctors, nurses, psychologists, social workers, occupational therapists. So I'm going to show you where we are now. Western Region still only has 1 psychiatrist in this service. When we compare to 2016, we did recruit and employ 2 persons, but they separated. We were not able to keep them, so we have to work on that. How do we keep our staff? We currently have 4 persons in training. The earliest person will graduate in 2021, and we are hoping that they will come back to work in the Western Region. In the interim, we will have to seek to see if we can recruit externally. In terms of psychologists, we've improved that. We had 1 in 2016. We now have 2, and we are recruiting a 3rd. There are some issues that needs to be addressed with this, and we are working, advocating for some of those matters to be addressed. Remuneration is one of them that needs to really be looked at. In terms of our mental health officers and nurses, we were able to move from 12 to 23 over the period. However, we still have not achieved the staff to patient ratio that we want. The international standard is 1 to 50. Our target is 1 to 200, and we're currently at 1 to 309, but this is coming from 1 to 500. So we're moving in the right direction. In terms of psychiatric nursing aides, we started with 22 in 2016. We now have 79 on staff. So we have made quite some gains with that. Social worker as well has increased just by 1. We lost our occupational therapist. I'm not sure if we were able to recruit as yet. I know we are in the process of doing that, but I wanted to highlight medical officers in primary care. In 2016, we had 37. We now have 56. The difficulty is that it includes entry-level staff, and you know these staff do not stay, so we have high turnover of these staff members. So that is in terms of our staffing. So we are improving in terms of our staffing. We still need to work at that and get additional staff. In terms of access to psychotropic medicines in primary care, I still give that a 3-star. It is free to patients at a point of access. We do have access, but we have challenges sometimes with maintaining a consistent supply in terms of that as well. One of the challenge I have is in terms of our prescriptive rights. This is not a very popular view. So I tread lightly, but I do believe that we need to really look at ensuring that our mental health nurses have the prescriptive rights to be able to function how they need to function. We have mental health coordinator in place in the Western region. However, they are limited in their role because they have to do so much clinical work because we just don't have enough of the persons. In terms of collaboration, I think we're doing relatively well with that. We do work with the schools, we work with Labor and Social Security, National Security. We have NGOs that we work very closely with, our faith-based organization, and we are strengthening our referral systems to ensure that the collaboration is fruitful. In terms of our budgetary allocations, we have challenges with this, even though we may say we're spending 6% of our health expenditure from our health departments go to mental health. That is my approximate assessment of what we have. We don't have really robust systems to assess that. In terms of the inadequate resources on the emergency community services, we're severely affected by that, but we improved greatly with our ability to respond in terms of the community. In 2015, we had one bus serving the entire region. We now have a bus per parish since 2019. We are trying to have an assertive outreach team that will improve the care in the community, but we have not yet achieved that. Our child and adolescent mental health is another area that we need to focus on. We have 19% of our users that are children and adolescents. We have no special facilities at this time, and we really would need to be able to train our healthcare workers to meet the needs. The Western region has in its plan, and we have started the Western Child and Adolescent Health Facility, and it does have the infrastructure in place for inpatient services for child and adolescent. So it may be a platform to improve this, especially the fact that we would have better outpatient spaces as well. And for substance abuse, we have little community-based resources on this side of the island. Majority are in the east of the island. Again, I keep talking about health information because we do have issues with our data management and getting data on our population and how to monitor what we're doing in the facilities. And stigma and discrimination requires continuous, relentless efforts at this time. So I think we've made some strides. I don't know if they're great, but I think we have to continue and work relentlessly. I've highlighted that we have to work smarter, but I think the strategic stakeholder involvement, we have to examine that a bit more. I think we need to look a bit more on who we're engaging and how we're engaging, and we need to reevaluate and monitor a little bit more. So what is the way forward? Primary care integration really requires at this point the primary care reform and strengthening that system that we've been talking about. There is a redesigning of the primary healthcare system that is in train and to start. That includes having better organization so that you have family medicine specialists who will stay the course of the service and you may not have that high turnover that we see at this point. Also, there's infrastructure improvement on the horizon in terms of our facilities. What we need to focus on, and I saw Dr. Wright speaking about the evidence behind this, but I think prevention is really what we have to look at. We need a more strategic focus on maternal and child health and focus really on prenatal as well as development from birth to 3 years. So we have started some work in our well child health clinics to look more at emotional development and cognitive stimulation. And we have had a new increased cadre of our community health aides. Westmoreland is the first parish that has finished training. And so we look to this also becoming a reality. We need to complete the institutionalization and reallocate our resources. And I saw this in Dr. Wright's presentation in terms of shifting that resource to the community to support community-based residential assisted living facilities. That really is something that we have to look at. Screening for mental and physical illnesses, we have to look at our screening tools and make sure that those tools that we use for physical illness incorporate the mental health aspect so that it is part of all of adult care, and there has to be monitoring and accountability. I can't speak so much about the resources. We need resources in terms of the social workers, especially if we're going to talk about self-care and improve community-based care. We have to improve the number of mental health specialists we have. We've made quite a lot of grounds in that, but there's much more to be done. And we have to resolve the prescribing rights issue that has been floundering for some time. The training of our health staff, the MH gap, I think it's really an opportunity that we have, and we need to use it more. I think COVID, I was trying not to use that word today, but I've said it. So I think COVID has taught us a lot about using these platforms that we're using to reach people, to teach, to interact. So I think we need to look more at making some of these available through recording, so people can go continuously online. You have the series of trainings recorded, they're available. It is mandatory that you go through it. You have 1 or 2 sessions that people come to ask questions and answers after they've done it. Then it would make training more easier on our limited staff that we have. We need the supervision from the specialists. We need a reorientation of our medical school training. I think mental health, just like surgery, pediatrics, it is a core specialty. It shouldn't be treated as a part of internal medicine. And so you need to have that rotation now in psychiatry, even in internship when you leave. Participation of mental health specialists in other general clinics. So this was one of the things we wanted to do in the West. Westmoreland has started this activity. So a medical officer is assigned to all the mental health clinics at this point. So that helps them to get their confidence up. They get to work closely with the mental health officers and become part of their routine and break that fear or stigma that goes with having to do this work. So they've started that. The vice versa hasn't happened because we don't have enough persons to be sitting in our child health or well child clinics and so on, but that too is needed. Health education promotion is very important to decrease stigma and discrimination, but I think the community integrated approach will do so. If we are able to train our community leaders or faith-based leaders and get them more involved in a formal way in the delivery of mental health services, you will reduce stigma and ease discrimination if people get more involved in that. So we really need to do a more grassroots integrated approach that involves the families and the community leaders. We have to continue to improve our health information systems because we have to be able to monitor and change with time and advocate. Everybody wants to know the benefit and what the outcomes are and what did you achieve and how many numbers you're seeing. We need to have robust systems so that we can continue to advocate from that level with the information that we have. So in summary, we have made some gains. I am the eternal optimist. So I will not say that it is not good in terms of what we have done already. We still need to increase our advocacy though, continue our training and research. We have to look at resources. I think Western Region has really been relentless at getting what they need. Dr. Crossman and her team, Ms. Rose, who will call you and continuously remind you that we're here and we need what we need to get the work done. And we have to remember that there is no good health without mental health. It's a nice thing to say, but it's really true. And holistic care should include holistic teams. So we shouldn't just be thinking that it is a specialist thing, but we have to have a holistic team that deliver the service. Thank you very much for listening.
Well, Dianne, thank you very much. Certainly no less than we've come to expect from you. I find it very interesting, and in the end you said you're forever optimistic, as you should be, that your stars weren't half a stars and so on, but instead a smaller star. That certainly makes it a little more palatable and give you hope that you can achieve a little more next time around. Harsh reality, Dianne, I don't expect you to say it. you know, I taught the things. If you don't have political will, it's not going to happen. That's really the point. And so that gets adjusted with advocacy. And that's our job. Our patients can't do it because they are impacted negatively by virtue of their illnesses. So it's up to us to advocate on their behalf to ensure that we move things forward a little more at a time. Many years ago, Professor Hickling, God rest his soul, commented on what to do when, like you have a basket to carry water. His recommendation was to line it with newspaper. He omitted one thing. God help you if the newspaper get wet. And so I'm saying to you, you have our support. We're all in it together. And we recognize the need for advocacy. We've been at this, toiling in the quarries for many years. Can't stop. That's just what it is. And so hopefully one day we'll be able to kick the door fully down and get done what needs to be done. So let me thank both our speakers. Excellent presentations. We covered many things, 2-3 days of conferences in the things you've both touched on, really. We have a little time now for questions and answers, and we don't want you all to ask at once, but let me start with a question I see here, and I'll just put this out there. Either of you may answer. Did the mental health task force precede the GAP action plan implementation? That's one. Let me just run another one. How can someone who does not work in the mental health industry help with all of this? Either of you, feel free to answer that. Let me just repeat it then. Did the mental health task force precede the GAP action plan implementation? And how can someone who does not work in the mental health industry help with all of this?
The mental health task force preceded the GAP implemented. The GAP implement the gaps. No, the GAP, PAHO GAP preceded the mental health task force, right? But we are still working on the gaps for Jamaica. Not only implementing some of the GAP, but putting in more service. So that part of it, the GAP preceded the mental health task force.
Okay. Thank you very much, Dr. Wright. And this one really speaks to stakeholders. Dianne, I don't know if you can comment. How can someone who does not work in the mental health industry help with all of this?
Okay, so that's one of the things that we're talking about. One is they can help even without training by getting involved. There are many community-based programs. I mean, in the West, for instance, we have COMI, we have WASP. There are many faith-based organizations that do outreaches and that work. But one of the main ways as well is to spell positive messages about mental health and mental illness and to discourage stigma and discrimination. That is a main way. I don't want to steal the minister's thunder, but even today I was so encouraged because I was part of the permanent secretary's meeting this evening, and the plan that is there for approaching COVID and mental illness is a great platform for us to continue on for the comprehensive review of mental health. And it will start with persons who do not work in the health service. They will be looking at training community leaders, community members who are interested in terms of basic mental health response as first aid responders and just that general training. So there are ways coming, but currently you can get involved by different community groups that are there, as well as in terms of what you say and do in terms of mental illness.
Thanks very much, Anne. Any other questions out there from anyone?
A comment. One of the things that I think it's Dr. Campbell-Stennett had it in her presentation, I think it's the linchpin, the training of doctors and health professionals at the university. I think that socialization that takes place there is deficient and needs to, a reorientation needs to take place so that mental health is really integrated into general health care. What you have Is it being parallel and on the side? I think that needs to be looked at. So the socialization, when a doctor graduates from the university, they are really understanding of mental health. I find individuals that are trained in Russia, Cuba, etc., have a better understanding of the emotional side of things than individuals. So I'm putting it, how are we? And that is for you, Winston. You have the key there to really do that.
Yeah, and you are correct. As you know, I did my undergrad in Hungary, so they too form part of that system where mental health is seen as a major component. There are some reasons for what we're seeing, Dr. Wright. As you will know, when you have a psychiatry department as part of a community health and psychiatry department, then you start with a problem, you know, and so we must make every effort to have a standalone department of psychiatry. And I know that there are persons working on that aspect. I certainly will continue to make every effort in my capacity as Deputy Dean to ensure that we can have that value of psychiatry represented appropriately, certainly far more than it is now. I have a number of other questions coming in. Let me just read one or two more. How do we promote the value of mental health through the provision of support for clinicians who seek to obtain training within the mental health realm? And what is your view on having a psychiatric unit in a general hospital?
Let me answer the second one first. As far as I'm concerned, there needs to be no more psychiatric units in a general hospital. The research is very clear on that the outcome is superior when you have the patient in a general ward rather than in a discrete ward for a psychiatry. The research goes that you have the best outcome on the general ward, second in the discrete ward, and the mental institution, the worst. The first should really be in the community if you can provide the resources to support the person in the community. And that's all according to how the brain operates.
And that's correct, Dr. Wright. And as you know, for a number of years now, easily 10 or more, we've been doing our training in psychiatry on Ward 21. In keeping with that, training our residents for managing patients on general medical wards, because in fact, that's where they then graduate and go on to take special skills. We learn them, and so we've been imparting that knowledge to the persons coming in for the training programs. Which brings us to that other question about training. How do we promote the value of mental health through the provision of support for clinicians who seek to obtain training within the mental health realm? So I don't want to comment on that. Certainly, we think we need to move beyond just allowing and facilitating training for persons who make an application to do a postgraduate degree. We must have things where we are clear on the need for the country on a national level, and in tandem with the Ministry of Health, determine what those needs are and make every effort to facilitate having the requisite numbers present in terms of providing scholarships, whatever you want to call it, support for persons coming into programs, as we do now, but certainly needs to be more. Just to quote some figures, so in my time, in the whole training program, it's a 4-year program, we had 6 of us total. I think that's now at, I think it's about 18. So that's some movement in 15, 20 years. It needs to be far more. And so we can't feel too comforted by the fact that we've probably tripled the numbers in 20 years. The point is, we're just scratching at the surface in terms of the needs of the country. And that's what needs to drive the numbers that we get in, the numbers that we can support and train. Any further comment on that, Dr. Wright?
No, I want to hear about Dr. Stennett, Campbell-Stennett, her response to that, because she always had very interesting comments on training.
I know. Go ahead, Dianne.
Really, I with regards to psychiatric units in general hospitals, I don't support those. However, I think that we have to look at how we design our general wards, because it can be disruptive and difficult. So we need to find a middle ground. So you're not doing a psychiatric unit. It's part of the general ward, but just like how you have isolation rooms, you have that. How do you have, when you don't stabilize the patient before they go, where is there a step down, a transition on the ward? So that's something that I would love for us to talk about and discuss. Because while we know the evidence, sometimes when you're applying the evidence, you have to find strategic ways to be able to get the partnership of everybody. So that's important. So how we design our general wards, we have to look at that as well.
Sure, but certainly not having literally a police cell at the entrance to a ward, as we had in a particular hospital on the North Coast. Took me a year to get that cell down. Can't have that, because that's not what we're about. But I fully appreciate what you're saying. Another question, what can be done if the medications that are used to help in the treatment of patients admitted to the hospitals aren't available? Very, very serious question, and very timely. Is there a mental health issue if one becomes nervous when faced with any kind of test? Well, the first, we can take first, what can be done in terms of medicines being available? So really it's around availability of required medicines in our medical facilities.
What we have had to do in our situation is purchase on the open market. So we have had to do that when medications are not available to supplement the supply. So we have had to do that as well. Sometimes it's just not available. We've had supply chain issues, which pose a different challenge, and then you have to find replacements or change a medication. But we have sought to prioritize in our region by buying the medication on the private market if it's not available in the public. I don't remember the second question.
So is there a mental health issue if one becomes nervous when faced with any kind of test? I guess jitters in terms of examinations.
Exactly. That's it. Well, as I always say, that everybody gonna have a mental health issue. Your mental health isn't as good when you're anxious, when the stress level is up. And when you have jitters, anxiety, what you are doing really is reacting to the stress so that you can perform, etc. So your mental health isn't as good as at other times when there is no stress or minimal stress. But at that time, you don't have a mental disorder. You're just like, if you have a cut, the cut gonna get better. You don't need to go to the doctor. The same principle when you have the anxiety relating to a specific problem that you're gonna deal with. You don't have a mental disorder as such.
Okay, thanks, Dr. Wright. I see Kevin is on, Dr. Goldburn, Dr. Leiber. Any comments? We've probably run out of questions now, but any final comments as we come to a close of our lovely and well-spent time this evening?
Kevin?
Kevin or Judith? Okay. Well, let me then thank PAHO, in collaboration with the Ministry of Health, Western Regional Health Authority, our own UWI Western Campus, the listeners, and of course, last but not least, our presenters for having taken us through very, very interesting areas of mental health, a number of specific areas in a very concise way and over a short time. I think those of us who have been aware of the challenges before are now strengthened that we need to continue our efforts at making every change possible, recognizing again that we must advocate for the benefit of our patients. That's just how things are structured. And I really look forward to enjoying the other days left. We go right into Sunday, if I'm not mistaken, on mental health topics. So once again, thank you all very much. I think the evening was well spent, and walk safe, hand sanitizing, distancing, mask every time for everyone. Thank you very much.
Thank you. Have a good day.
Thank you.